everyone. Can you hear me right? Awesome. It's really great to see real deep techies in one room, and also for 3 days if you're leaving your job and coming here, and you're really serious about what you want to learn here. Unlike the previous speaker who did an excellent job of trying to give the behind the screen and under the hood of a wonderful technology that can actually help and have many use cases. My talk is going to be slightly higher level. I'm going to take you like 3,000 foot, little higher, trying to give you some real use cases where technology is being used to save lives, particularly coming in from our own experience building this startup we call Niramai. And Niramai actually means being healthy in Sanskrit. Sarve santu niramayaha, let everyone be healthy is our motto. It has an expansion, non-invasive risk assessment through artificial intelligence. So that's what we are attempting to do, trying to use AI and machine learning to save lives. And the first problem that we are attempting to solve now is breast cancer. Breast cancer is one of the largest cancer killers in women. 500,000 women die every year because of breast cancer. 1.7 million new cases coming in every year. The unfortunate thing is, though breast cancer is completely curable if detected early, every alternate lady detected with breast cancer is dying in India. 86,000 women died just like that, just because there was late detection. People wait till there is a huge lump before even coming to the hospital. There's a huge awareness issue, but there's several technological issues which we believe can be solved using machine learning. So in the next, I guess, 45 minutes or so, first 20 minutes, I'm going to just talk to you about the end use case, how this particular, let's say machine learning and so on can help the whole thing. And then last 15 minutes or so, I'll try to sort of give you a feel for what type of algorithms and what type of problems exist. And if any of you want to collaborate, happy to sort of open it up and then have further discussions and so on. So early detection is key. And first thing you want to check is, why is early detection not happening? What are the hurdles? What are the techniques available today for breast cancer detection? The most commonly used cancer screening method, not just for breast cancer, for several other cancers, uses X-rays. And we all know X-ray means radiation, and radiation can increase the risk to cancer. So the best solution that's available today is mammography, which, if used every year, can actually create mammography-induced cancers. Small percentage, so be it. Or I can say 5 continuous usage will increase the probability above 0.5, which is good enough to say that there are a few cases. Let's take that is the solution. That is also very expensive. It's about 3,500 rupees per screening. And in India, nobody wants to spend that money every year to detect early stage, means not wait till end. Like, you need to go for regular screening, regular preventive checkups, and so on. And that's a lot of money. And then it's, because the machine itself is like 1.2 crore rupees and all that, small diagnostic centers are not able to afford those machines. So it's available only in cancer hospitals, big multi-specialty hospitals, which means women have to go to that cancer hospital to do this regular checkup, which again is a huge hurdle because nobody wants to go to a cancer hospital. What if somebody sees, and why is she going so often to a cancer? All of this social stigma associated with this as well as obviously rural India doesn't have access to it at all. We talked about radiation. And the last one is very interesting, the technology limitation. Here, the technology doesn't need to be a computer science technology. The physics with which this X-rays work is the density differences, right? A higher density thing appears whiter in an X-ray and so on, like if you take an X-ray of your hand, the bones appear white, obviously because of high density, right? So if that is the technology, that is the intuition for mammography to work. So the doctor actually stays at this X-ray of the breast, where if there is a lump, there is a white spot and so on. But women under 45 years of age have dense breasts, which means a lot of fibroglandular nature, so the whole X-ray appears white. And how do you find a white spot in it? Yes, there are some machine learning techniques that are being developed to make this possible, make it useful, give tools for the radiologist to detect it. But then we thought we have to try with a completely new way. If something has been around for 35 years and you want to try and sort of make it better, you can only do a few percentages better, right? So we said, okay, can we look at something that kind of addresses all other hurdles as well, the affordability, accessibility, the non-radiation bit, as well as work for women of all age groups. So we found that there is an imaging modality. In fact, we started with a multispectral camera, looked at different bands and said, okay, where is the highest level of discriminative power? First, visual discrimination, and then we look at how do we actually develop the algorithms on it, right? And we found in also literature, medical literature, that people have tried infrared imaging for detecting breast cancer. Of course, they were staring at the image, and the infrared cameras are much higher resolution now, so you can actually get more data. But let's say you're looking at even a high resolution image like this. What is this image? This is just a heat map. You just take a shot, and what you're seeing there is every point here is the temperature at that particular bunch of tissue, if you will. So it's just a simple heat map of temperature values. And yes, a small variation in the temperature can actually be detected. The sensitivity is like 0.05. And then this is like any other megapixel type scan. There are different resolutions we can talk about. We have just started using 320 by 240. That's good enough for us to get a good enough view for the analysis. Obviously, higher resolution you go, the cost increases. So when we start with this thermal imaging device and solution called thermography, which is measuring the body heat, and for several purposes. It can be for building maintenance, it can be for surveillance purposes. If some of you would have seen the movie Uri movie, right? Now you generally place this thermal imaging device across the border, and the rest of the temperature in the environment is about like 0 or 4 degrees. The person's temperature is 37, so any human being or animal moving across the boundary can really come out as this red thing, and that's how it's used for surveillance purposes. You can easily develop algorithms to catch that. In fact, there are weapons which are fitted with thermal imaging devices, so that if the person is shooting somewhere else, it kind of realigns it as well. So I was talking to one of these friends and said, you're using thermal imaging for killing people, and we're using it for saving people anyway. So that's sort of the picture. Coming back to this, so what was there in the history is to use thermography for detecting breast cancer. And one of the prominent features of breast cancer is it starts with one breast. So there's a clear asymmetry. And when there is higher metabolism, there is higher blood flow, higher temperature, as well as the thermal asymmetry is around the lesion as well. It need not be just at the cancer area, because the blood vessels are all over the area, you will actually see a different heat pattern. And when you, like all other places, if you start doing subjective analysis or human-based analysis, there's a lot of errors that can creep in. Here we are about 400,000 temperature values the doctor has to look at. So obviously, that was a nice place for machine learning to play, right? So we just call this technology as thermal analytics, where we take these thermal imaging thermal images and perform machine learning on these images to have the software which generates a report automatically suggesting the level of abnormality in the person. Obviously, it's very, very useful. It is highly sensitive because literature has shown that thermal abnormality is the first abnormality that many diseases show, including cancer. First, as small as 4 mm, 3 mm is something that we are able to detect, as opposed to 2.5 centimeters, 25 mm, that can be detected by hand. So it's like stage 0, even according to the norms called TNM staging. So it's highly sensitive, and it's a very small device. It's like this big, and I didn't get it here, but it's a very, very small device. So you can put it in your backpack, go outside, do the screening, not just in the hospital, but also outside, and so on and so forth, for rural screening as well. It's completely safe, no radiation at all. It's just measuring the temperature, right? And you don't worry about how many times you put the thermometer in your mouth, right, when you have fever and so on. So it's absolutely safe, as opposed to mammography, which can only be done once in 2 years, right? So that's all this. And now the rest of the magic, and to make this really work, to make it really objective and quantifiable, right, that's where the machine learning comes in. So I'll just give a marketing view of this and then go into how the machine learning, right? So what does it enable? By putting this technology together, what does it enable? Niramai's solution now can detect very small cancers, as I mentioned, 4 mm, before a lump is felt, as well as it can work on women of all ages, because it is not dependent on the density differences like before. It's a real variation in metabolism that we are detecting, and that is uniform across any age groups. The rest of the things are great. So this is how small the device is, and this is actually installed in 50+ hospitals. And we train simple nursing staff to do the test, because if you make it very, very difficult to operate, then actually there is like 1 doctor in 1,000 villages, right? So you can't really scale it up. It was important to dumb it down. What does it mean to a technology? Once you dumb down the usage, all the smarts have to be taken up by the system, right? So we have to make it completely rugged to usage. Anybody can make any mistake. Still, we have to give the right results. They can make errors in image capture. We need to give the right results. So all of this comes up back as additional challenges that the solution has to take care. And all the machine learning algorithms and so on reside on the cloud. So there's this device connected to the laptop, and these kids are actually trained to do the solution. Like I mentioned, it can actually do it outside. This is seen in a corporate camp. I think it's an apartment in Prestige Shantiniketan. This was conducted. You see 2 booths, a lot of people waiting to get the screening done. Recently, we also had Sakra, sponsor, even Sakra and Rotary come up and made a mobile van as well. They just, modified it. It's important because if it's a mammography, right, because of the X-ray, the bus has to be very different. It has to be thick walled so that others don't get affected by that as well, right? So this is a very simple process. So any bus can be modified to do this. So next, I'm just going to be a 30 seconds video as to the experience, and then we go into the internals.
Tested the Niramai technology to me. Having heard about it, I went to get a checkup done. I was quite skeptical before I went for the test. It took me by surprise because the machines didn't touch me. It was all happening from far away. जैसे eye test होते हैं ना, दूर से बिल्कुल वैसा.
Yeah. So as you can see, the current methods of detecting breast cancer was using X-rays, and in fact, one more thing I didn't mention is the experience is extremely harsh. 10 kgs of weight is applied on the body, and the person runs crying after the test, and there's somebody else touching you. It's really, really horrible experience. Whereas here, it being very privacy aware, a lot of people want to come in and take it. Just the person enters the booth, she comes out after 10 minutes, her report will be ready real time. So this is how one of the reports basically, for example, looks like. So we have multiple scores that we generate, depending, because whenever we're talking about healthcare and AI, the combination, you're dealing with doctors. When you deal with doctors, you can't say, yes, my DeepNet gave me that it is 0.8 probability that belongs to this class, and so this is. No, you have to tell them exactly why you think that there is cancer in this person. So what that means is we need to give different, semantically readable, understandable, interpretable values. So we give several parameters. Some of them only have been shared here. we talk about how the asymmetry is, and we also give images where we mark the exact area where there is likely to be malignancy. And then there is a further test done with ultrasound or something, which is like much more costlier inside the hospital, where they check those tissues, take out the tissue, do the analysis to see whether there is real cancer or not. We give different scores, but when you go to the real, sort of the rural areas, you cannot actually have a 3-page report that is generated, printers, and so on and so forth. We anyway need to bring them back, so we give a real-time automated screening with a red, yellow, green, which is saying, okay, what is the follow-up required, and so on and so forth. Now, in the original case, the report automatically goes to a radiologist, a panel of radiologists. We figure out who has to get which image, and then it's a certified report that is generated. So end-to-end solution should look just like any other test that we all would go and take it in a hospital, right? So for that, what are the things that are needed? And where did we start? And how did we start, right? So essentially, this all started with a small episode in my own family where I lost actually 2 very close members to breast cancer. They were just in late 30s, and they both had very small boys. And I've seen how this whole thing affects the family of the lady. And so I said, okay, I was actually heading analytics research for Xerox Research India. We had wonderful, solutions we were developing for the global scene for smart cities, other healthcare, predicting mortality in an ICU, and several interesting healthcare problems as well. So I thought, let's start looking at this problem, and that's when all these things happen. But then, as you can imagine, we are not using thermal imaging in the hospitals today. I didn't have millions of data to just get started. It was a thought, like, if some in books they have seen, yes, they have used thermal imaging. So how do we start? So one of my close friends, Mesta and I were there, and then we were working on some other problem with the doctors. So first thing we asked is, and that was a surgeon, and he was also doing breast cancer surgery, which is called mastectomy or lumpectomy. And so we asked them, can we try? We have a multispectral camera. Can we try and take some 2 images, subjects? And he said, yeah, sure, because the literature says it is, and there is no side effect, so we can take it. So we didn't know what type of imaging needs to be taken. So we said, okay, should it be video, audio? And we looked, image. And then we looked at the protocols that were followed, like in 1980s and so on. And then we found that they were actually cooling the body before taking the image. Of course, we took the image as it is. Everything was red. It was not even as good as what you saw there. So we figured out that there is a cooling protocol that needs to be followed. So we said, okay, fine. We keep the person 10 minutes in an AC room and then take the image. So we made one of the patients sit, ask her to rotate on a stool, because you have to do it. Usually you need to have a sophisticated image, like, if you do an MRI and all these big things, right? You go in and everything moves around. We can't have such kind of a sophisticated one built. So we took a simple thermal imaging device, put it on a tripod. We got a simple stool and made the person rotate. So we get the 360 degree or 180 degrees view of it. So we took 2 such videos, and so I said, okay, and he was more of an imaging person, so we were staring and saying, like, can we do something with it at all? I said, yeah, see, there is some hotspots here, and there it's not, because we knew the ground truth. We said, like, what's kind of, different and so on. And said, okay, so let's have a proper protocol, set it up, and then see how, this variations happen. So we actually collaborated with hospitals, and some of you may want to do a healthcare, ML and startup or whatever. You'd really need a proper ethics clearance to actually take a lot of data. So we set this up and started off with like 10 subjects and so on and so forth. We didn't have a normal subject because we were only subjecting people who were going for a surgery. And it was very difficult to catch hold of somebody and say, why don't you sit in front, right? So finally, the nurse who was taking this, imaging for the others, because it was not in Bangalore, it was a little far away. And so that's when she said, okay, I have seen, I've taken, it's not a problem. So she went on the other side, and that was the first image. And that's when I thought, okay, definitely we can find something very drastically different between a normal subject and somebody who's going in for this thing. So the first few versions, right? We built a Matlab thing, like many of you would have done, right? To just see what kind of things, what kind of mathematical properties we can actually extract out of this, right? Imaging properties we can extract out of it. So it was a video, so we looked at, temporal aspect and, view angles and so on and so forth. And we looked at isotherms, localizing the boundaries, are the boundaries looking different? And then we showed this to the radiologist. Like we finally got about 70 different images, and then we sat with the doctors and said, where exactly is the cancer when you're doing surgery? And sort of we tried to sort of map that and so on and so forth. And also we did like some kind of, a 3D modeling to see how is the intensity varying? Is it only in one place or different places? And so on and so forth. And then we also studied to the extent of like different types of subjects, right? One is of course normal and malignant, but you would know, right? Somebody who has a lump, who has some signals, but it may not be cancer, benign conditions, benign lesions. There's different types of benign conditions, fibrocystic, fibroadenoma. There's several papilloma. There's so many versions, variations of this. So we kind of tried to see, okay, can we look at thermal images across these? Because one thing you should be very clear is that when we are coming up with something that is for a cancer patient, both false positives and false negatives are harmful. False positives are harmful because if you call somebody and say, okay, you may have cancer, though you do the test, half an hour, immediately you do another test and say, no, you don't have, but that sticks in her mind. That particular test on that particular day said cancer, throughout her life she'll be struggling, right? So it's very important to have low false positives. It's also very important to have low false negatives because all that you're doing is to catch cancer and you don't want to miss cancer as much as possible, right? And so it's really ask of close to 100% sensitivity and specificity. Obviously, it's not feasible, but that's what we are attempting to do. So you have to look at several other subcategories, like I mentioned. So we did that, and we kind of analyzed. And then I'm giving you a subset of the features, which was all hand-coded. These are like 30 patients. You cannot do deep nets and so on with 30 patients, right? So, and also video taking and uploading to the cloud took so long, right? And so we said, okay, can we optimize on it? So we discussed the protocol, read about it, and said, okay, 5 images are more than sufficient. Frontal, left 45, left 90, right 45, right 90. So this is sort of another angle that came in, where looking at several statistical elements, we said, okay, why don't we make it like something that depends on, okay, this list is mainly meant for doctors, so we call about vascular feature, non-vascular features, the thermal aspects of it. We look at the boundary conditions, the irregularity in the boundary. That's important because doctors understand that when a tissue is affected with a cancerous cell, it grows at a very abnormal rate. It's trying to eat up the food of the next and so on. Irregularity is the very common aspect that they're able to relate to. So the irregularity in the boundaries and so on and so forth came up as some explanation of the features that we were using and so on and so forth. So at the end, this is the slide that the doctors understand. We say, okay, there are 4 different women here. The bottom 2 are not cancerous. One is completely normal, and then there is one who's a lady with the breast cancer, right? So how do we detect that only that is cancerous and not this? And so that's when we basically mentioned about all of these features. We have 110 handcrafted features today, plus features are not just 1 or 2 elements, they are patterns. We are able to actually analyze vascularity, that is from a thermal image, getting the blood vessel structure and how many sort of, the count, the structure of the blood vessels and so on and so forth also are helping that. So with this was not the ending, right? So with that, we did get some good results. I'm going to share some numbers as well. But then we figured out when we actually put it, the researchers cannot be on the ground to start taking the images, right? It will be somebody else, like I mentioned, right? Some photos of the nursing staff, right? So they make a lot of mistakes. So we, in fact, of course, all this resulted in 9 granted patents, and some of the recent patents are all about, is the image good or bad? What is good and what is bad is like multiple elements, focus, position, cooling done or not, several parameters there, each of them requiring different types of machine learning algorithms. And of course, this is the place where you can easily use deep learning, and that's what we're using, because now we've done 16,000 women, which is like into 5, and some videos, all this coming up to like more than lakhs, I would say, of images. And so we are able to use deep learning right now. And also you do, pattern synthesis also. We started using GANs to synthesize these images as well. And so we, of course, we have a lot more synthetic images as well. So using that, we were able to develop a lot of these deep learning models for that. And one of them I'm going to share a little more detail. And then, so one other aspect is the auto tagging part. I said we will have like 5 images. The easiest one where a CNN worked very nicely was when we did tagging of which view it is, right? And it doesn't matter whether a person is cancerous or not cancerous, even normal images. That was important because people, we're talking about health workers, they were naming left as right, and all kinds of errors were being made. So they said, okay, that is the minimum that we can easily do. So that tagging also uses deep RNNs right now. And then we have the ROI segmentation. We take the complete image on the upper body, and then we need to sort of analyze the actual region of interest, which is the breast area. So there again, what we did was initially we developed the imaging algorithm, and I'm going to share a bit about it, and then we kind of moved where that's where deep nets are working really, really well. And then the hotspot localization angle and a lot of feature extraction, some of it actually again requires machine learning. All of these actually have a lot of machine learning problems, smaller ones, identified and so on. Like for example, what's the breast density, whether this person can go to mammography or not. Several adjacent problems that have been. Another interesting aspect is we found that when we started analyzing these positive cases, without touching the person, just with thermal imaging and of course the machine learning piece, we were able to say whether the person can be cured with a surgery or not. The treatment guidance can also be given. Of course, it's at 85% accuracy, which is not good enough, so we have not released it, but this is something which can say whether she can be cured with drugs or she requires a surgery. And that's very important because the only way to get that is actually doing a surgery is the only way you can actually get this today, the hormonal response, the HER2 negative or not. So all of those things, and we also, because we were in the breast cancer scenario, we said like what other things we can do. So we looked up data that's out there, BCDCS data, which we use for risk modeling, right? Just questionnaire-based risk modeling, and again, there we found that deep nets actually help in addressing missing data. Whenever you're doing a risk modeling, that is you ask a questionnaire and then say, okay, what's the age and whatever, like different questions you have. Many people will not answer all the questions. One, they may not know the answer also, they may not want to reveal. So handling missing data or even incomplete data is very important, not just here, but for several healthcare problems, right? So we found that the best rugged model that works is, again, here we just used CNN, and that actually worked much better than SVM or logistic regressions, so on, where we synthetically modified the number of errors in the data set, and up to 50% of errors is what DNNs were able to tolerate. But anyway, there are several learnings on the different models we have built. But just to give you a next level view of another angle of ROI segmentation, we take the image, and initially we developed it as an imaging algorithm. So we said, okay, body contours and so on, so we got this. And then the lady used to, the technician used to move that around. It was pretty okay, but actually when we tried looking at what is the exact value and do the dice coefficient and so on, it was just about 0.7. So we modified using CNN, and also we used VNet actually. So what we did was, the segmentation was dependent on the view. So I mentioned about the view model, which was working very well. So we coupled both, and sort of the number of cases can be increased if you just sort of swap it, right? Flip, left becomes right, right becomes right. And so you only have left side ROI detection you're doing. So suddenly it doubles and so on. So we used a ResNet 50 as usual for some loss functions had to be modified to make sure that we get the right results. And also VNet was good enough for the segmentation because it's the tagged answer that's coming in. Just to give you an idea, so it became a view-independent model, depending upon, irrespective of the position errors and so on and so forth. And this is more like the imaging method, and the green one is what we are getting. So there are several things, innovative stuff that we could do, not just in tweaking the DNNs, figuring out what problems will be interesting here to really make this work and so on. So at the end of the day, so far I think like 18,000 plus patients tested so far. And what the doctors want to see is how are you doing with respect to mammography? How are you doing with respect to hand examination? How are you doing with respect to thermography? Thermography has been around for 30 years and we are not using it. Why should I use yours? So the first thing we did was, can we compare with thermography, the manual interpretation? Obviously, manual interpretation has a lot of subjective errors, but these are the doctors who were 15 years experienced in trying to figure out whether there is cancer or not. And one of the papers, this was published in a Kyoto conference, a medical conference, where the doctor himself, or thermographer, Dr. Ramprakash sir, who went there and presented this, and we found a huge increase in positive predictive value. That is, once you say positive, how confident, what is the likelihood that it's actually positive? I know you know all these things, but anyway, so there's an increase of 70% in PPV, which is very important. I talked about the false positive angle, and controlling that was important. And when you look at sensitivity, in a 303 patient thing, we missed one, and then we now fixed it to take care of that. And so it was really close to 100% sensitivity that we were able to get. And in addition, because of the several camps we've done, Karnataka Cancer Society has given us a recommendation saying this is the one which can be used for population screening, and so because of that, we could get more and more. Just to give you an idea, every person takes 15 minutes, so in a camp we do about 20 people. Still, 16,000 is as many camps, right? It's a lot. And yeah, we did compare with mammography as well, and it was very interesting that we were adjudged as a breakthrough idea. And in ASCO, which is the American Society of Clinical Oncology, where there's a lot of these oncologists and radiologists who come in, presented this in Thailand last month. And we actually separated symptomatic and asymptomatic patients. If there is already a symptom, obviously she'll go to a doctor. But can we detect cancer in even cases where there's no lump or whatever, right? So there we actually got 100% sensitivity, where mammography missed quite a few of them. Because of the issues that we mentioned before. So this was, again, like the breakthrough conference presentation. And I think some of you may be thinking, is this only for breast cancer? Can I do it for other things and so on? Yes. In fact, this is measuring abnormality irrespective. Of course, breast cancer has an opportunity to save millions of lives, and so we picked it up. But it can be used for several other types of cancers which are closer to the skin, because the temperature has to sort of move to the skin because we are measuring the skin temperature. In fact, we have a research in trying to do 3D modeling inside the, what we are seeing on the skin is this, but wherever is the lesion, it can be much deeper. So how does the heat from the lesion really transfer to the surface? So we are doing a lot of thermodynamic modeling of the organ and so on and so forth as we speak. And so it can also be used for several other types of cancers as mentioned here. As an example of this, what we did was, this is Bill Melinda Gates challenge for riboblindness. It's called onchocerciasis in medical domain. And this particular disease is making 50 million people going blind every year in Ghana and other African countries. And so we said, okay, can we figure out, is this useful here? Why is it useful? Because today, people will have some kind of that small nodules on the skin. And the only way to figure out whether there is a parasite underneath or is it infected or not is to scrape off that and put it. Otherwise, even a fly which is biting him and going and biting somebody else would actually contaminate. So it's an infectious disease which cannot be controlled without scraping off people's skin, which is like crazy, because you can't even develop a drug. Because if you're here is a subject, you're giving him drug to figure out, whether he's becoming better or not, the only way to figure out the person is becoming better or not is to scrape off the skin. So how do you even check the efficacy of the medicine? So it's a huge problem, and so we made this a non-contact way of detecting number of parasites, or at least volume, like, high, medium, low volume of parasites under the skin. It's in stage 1. We've already got some good results of figuring out whether the nodule is live or dead, but it's an excellent opportunity for us to sort of get reviewed. Our algorithms and all were reviewed like 6 months by very key specialists from Bill and Melinda Gates Foundation and so on. We're very happy to be working with them as well as we speak. So in addition to sort of these, we've actually received a lot of other awards and mentions and so on. But one of them, which I'm very, very proud of to present in front of you, is that we are listed on the top 100 AI startups in the world, the only one from India which has ever made it to this list. Thank you so much, and happy to take any questions.
In case of any questions, we have mics right here, requesting you to kindly please come in the center. Use the mic and you can ask a question. The mics are right here in the center, requesting you to kindly just get behind. Use the mic for the question. And also, we are circulating the mics from our volunteers. In case if you can grab one mic, that would be really great.
Hello.
Hi. We have our volunteers around.
Yeah. Very inspiring and a very informative talk. What stops you from this being accepted across India or maybe even the world? And this community here, how can we help you? Right. Because this is 90% men, but from my personal experience of people in my family being affected, I would like to help personally. I would assume others too. So what do you need from us?
Sure, sure. Thank you so much for offering that. So a couple of things. One, I'll address that last bit. Men get breast cancer. I'm sorry to shock you. There are many or most male, men don't know that this happens. Men get breast cancer and gets detected in lung or brain because that's the second site this goes to. So, because it's not even common, right? I mean, like, how can you imagine? So that's why, in fact, I had it in one of the slides where we initially said, okay, everybody needs, just like you do X-ray every year or whatever, right, of your chest, do a thermal scan every year. It really helps, and we've done more than 24 men, with this, and there's a whole male breast cancer consortium. So that's sort of the one bit of it. Just wanted to, thanks for asking and letting me share that with this audience. Coming back to what stops us from going beyond India. So any health tech innovation requires a lot of regulatory clearances and clinical acceptance from doctors. I'm assuming there's no doctor here and I can go, and my Dr. Giri is more the PhD part, not the domain. They are actually serving people. One, they don't have time for innovation or any new thing, right? Secondly, they're working at the brink where they're helping people to figure out if there is life and death kind of a situation, right? So that's why they have to be very, very sure that the result of the tools they're using is much better than what they already know or have been using. So this basically means if Dr. XYZ is convinced and he's using it, doesn't mean that another doctor will just go by it and then adopt it. Every person wants to evaluate, and we are fine. So typically, any conversation says like, this is great because I know there's a huge limitation of mammography, and now can I try it? So there is a 2-3 months of trying, and then they'll all get convinced that we are able to detect, and then so there's this conversion thing. And also there's this regulatory part where the Indian government has a DCGI clearance, and you have to put up a lot of, it's a process we need to follow and so on. The good news now is we are less than 3-year-old, but already cleared in India, and we are installed in 50+ locations because 30 is like real hospitals, and 25 are government hospitals where we cannot install it because the device is about 10 lakh rupees. So it's like, I can't fund it from my startup for everybody. So for doing free screening. So what we have done is we have a team which goes to different government hospitals in Bangalore and does the screening once or twice a month, which is announced, pre-announced, like a calendar which goes. So yes, it is being used in 50+ locations today. To go beyond, of course, we need to go for US FDA clearance, which requires a clearance or a trial to be done on US patients, which is, we're working on. In fact, Stanford Medicine Center has agreed to do this, and we'll be doing one trial in Japan as well. And so we're trying to sort of do it in multiple places. It takes time to sort of get each of these moving. But I'm glad that there are really, radiologists are more tech savvy than others. So we are actually more than 6,200, actually 6,200 radiologists are already on board with this, and they are questioning, but only thing is they want to try on their patients first before doing, and we are supporting that very much. So to the last bit of, how can you all help? Obviously, we are hiring. So if this excites you, please apply. Thanks for allowing me to say that. And we do have a lot of internships and so on. Why? It's not, every bit of it is a very, starting from an ROC AUC of 0.85 to, in the ROC curve, I mean, right? 8.5 to 9.3 to, I think we've reached 9.5, which is like pretty good. So for all of these, it requires not just data engineering, a new thinking as to what else we can do and so on and so forth. So really smart people will really help. Another big thing that we want to do is to reduce the cooling time. Right now we need like 10 minutes to cool the person before we actually do the imaging, which becomes a little bit of an issue when we do large scale screening. Because there are lots of people waiting, 500 people, and you said I can do only 50 people. Obviously, that's why we brought in all these risk assessment tools and all that thing. So now we are trying to see how to sort of remove that cooling part by taking some video, trying to use temporal aspects of that to actually detect. Let's see, we are starting our research collaboration also, but any ideas and new ideas on video analysis, we'll be very interested in trying this out as well. Thank you.
Hi. Thank you, ma'am. We work for the Ministry of Healthcare,
awesome.
And we work with multiple state governments, including BMGF.
Okay.
And we help in the government to formulate the right schemes in terms of reaching to the healthcare to the last mile. And in doing so, as you are aware of, ma'am, it was very fascinating. And we were contemplating the Anganwadi route in terms of when you talk about maybe mortality, which is working, where on the Anganwadi worker goes there, takes an image, takes it back, and then we can give them a suggestion, maybe interiors. So as I understand, this cost is very high in terms of the device. Is there a way we can use this Anganwadi route and take that to the last mile rather than taking them back to the hospitals? Is there a way you are thinking, ma'am?
Yes.
Your view on that. Thank you.
Thanks for asking it. So obviously we wanted to reduce the cost, and of course we could start manufacturing thermal imaging, but we don't understand that hardware as much as we should be doing to build it. So what we saw was there is a much lower resolution thermal imager available that can be attached to a mobile phone. So we do have another project called My3, which is like an attachment, like a friend, where it's just an Android phone or an iPhone, attached a small device. I didn't get it today. It's a very, very small device you attach. That becomes a thermal imaging device. We have now developed a software. You can go to Google Play and it's there, Niramai Doctor it's called. So we can download, and this can be used to screen, just for the RGY, because it's lower resolution. We don't want to take the risk of sort of saying exactly where it is and so on, because we may, and we're also trying some super resolution techniques. And again, if there are super resolution experts come in and help us do better, right? So that we're trying to do so that, we can bring up the resolution so that we can run the rest of the stack easily. For example, with that kind of resolution of 120 by 160 and all, we're not able to get the vascularity. So that piece is gone. Having said that, this whole device, just, with like 50,000 rupees or something, you can actually, our at least vision is to put that in every PHCs, like Anganwadi you mentioned, right? So happy to collaborate if there is scope for doing that. Thank you. We are actually using it in Maharashtra District Hospital, Bhopal District Hospital, Bangalore, as I mentioned, and Punjab, and so on. So happy to, that's where the rubber meets the ground, I think. Yeah, thank you.
Due to time constraint, we shall be taking one last question.
One last question.
Hi. Hi. Thank you, ma'am, for this wonderful story. So I am Vidyut. I am from Honeywell Aerospace. I too studied in Indian Institute of Science.
Oh, cool.
So I have two questions for you. The first one is, so for building or training a machine learning model, you need lots of labeled and annotated data. Yeah. So how much are you spending with the radiologists or acquiring for this data? Okay. And the second part of the question is that, are you using some unsupervised learning methods to label or annotate this data instead of spending
I'll answer
on
the
that?
annotation question. Good one. I should have actually said that. Thanks for asking that again. Yes. So most machine learning models use human annotators. Our machine learning model does not use human annotators. So what we do is we said, okay, let's get 3 thermographers and then to analyze. Believe me, there's only one thermographer in India who can interpret, and he is Dr. Ramprakash sir. Or maybe there's one more. I haven't had an opportunity to meet him. So how do we get 3 to 5 experts to label it with a positive or negative to actually train the model? So we thought through this and then said, okay, let it be a little costlier or this thing, but more accurate approach. What we do is, anyway, doctors are saying, is this better than mammography? Is this? So what we did was we made the person go through our test, followed by mammography, ultrasound, and 2, 3 other tests, as well as biopsy. Biopsy basically, or an FNAC, is basically a pathological test. You take out the tissue and then say whether it's positive or not, right? So what we've used was the biopsy results to train the model. So now it becomes better than mammography, all of those, right? Because that's the real ground truth, right? And that's what we used. And on hindsight, it was actually an excellent strategy that we used. Thank you.
Thank you. One follow-up question, just one.
I think there's one more person waiting there, maybe.
Just
Thank
one follow-up.
It's a related question. For bootstrapping, when you had limited data, how did you do the feature engineering?
Yeah, so I think I gave some hint of that. We didn't know where we were going, really. So we started off with 20 features. Obviously, some are very obvious that there is a difference and so on. Like what you would have also done, several features we added in, like, all the statistical parameters. We did a PCA, got that out, and then we were getting a lot of false negatives. We were missing many cases. Then we used unsupervised learning to cluster the false negatives to see, are there some common patterns among these, which is clustering with simple imaging parameters to figure out, are there some new things that are being shown here. So then we pick that up and then make that engineering and then do it. So it's a long cycle of little bit of a hand coding thing, but now we run this to a deep net, put that 124, say PCA karke, we just reduce it to 512, add that as an additional set of features. All that we are doing to have this sort of additional piece. Yeah. So maybe.
So ma'am, one final follow-up question. So very interesting one. So from a business standpoint, true positive, false positive or false negative, which is a greater cost to the business?
Okay, so
also factoring in the compassion towards human being.
Right. Compassion-wise, it all depends on how you message the answer, right? I never say red, it's only this audience I'm saying red and all those things. We give a different message altogether. And as long as your messaging is good, even false positives can be manageable, right? And so there's some, I think it's a longer thing, but there's something called rule in and rule out test. So there are cases and use cases where ruling in is important, that is who is cancer. In some of the cases, like in diagnostic scenario, ruling out is important. That is, she is not cancerous, and saying with high confidence is important. So screening, it's actually ruling in. Diagnostic, it is ruling out. So that's why you see asymptomatic, symptomatic, different answers. Thank you. Excellent questions.